department head. He's a fantastic researcher, and he contributed understanding of tubercular granuloma and a new treatment modality, moxifloxacin and anti-VEGF agents. It's a very good contribution, and we are going to listen to him from her role of diagnostic vitrectomy and AC-TAP in uveitis. I thought that these are the very important and relevant topics, but unfortunately we didn't have that much audience.
Thank you, JB sir. And I'll be briefly discussing about the role of diagnostic vitrectomy and AC-TAP in uveitis. As far as the AC-TAP is concerned, it is always important when we have a diagnostic dilemma. It's a minimally invasive procedure and it's quite safe, which can be easily performed as an outpatient procedure. It helps in diagnosing and excluding malignancy and infection in patients with ocular inflammation. So what are going to be the indications of an AC-TAP? It's primarily going to be an infectious keratitis, endophthalmitis, and infectious uveitis. As far as non-infectious is concerned, it can be a non-infectious uveitis, any underlying masquerade where you're not able to identify the cause of inflammation, an atypical response to therapy during the treatment of presumed autoimmune intraocular inflammation, and also to collect a sample for cytochemistry and cytology. So we should not treat that as with a low priority, and it should be taken as any intraocular procedure with an informed consent. Topical anesthesia should be given, aseptic precautions should be taken, and it is best done with a 26 gauge needle loaded on a 1 or a 2 cc syringe, and 0.1 to 0.2 cc specimen should be collected. So this is just telling us how the procedure is to be done. And if you are having the exudates collected in the lower part of the anterior chamber, then it is best that you direct the needle towards those exudates rather than in the serous or the clear aqueous humor, because that is not really going to help us in getting anything on doing a lab investigation. So these are certain things we need to keep in mind. And also, I usually prefer a 2 cc syringe over a 1 cc syringe because the plunger goes very high for you to be handling it with one hand, and in a 2 cc it is more comfortable to handle the syringe, the plunger of the syringe. Coming to diagnostic vitrectomy indications, it can be planned for an intermediate posterior pan uveitis of unknown or suspected origin where conventional methods such as the clinical assessment and lab investigations have failed to determine the cause. You also can have a strong suspicion of an underlying masquerade, a potentially sight-threatening uveitis with negative labs and ancillary investigations. And when you are dealing with an atypical presentation of uveitis, it is better to resort to a diagnostic vitrectomy. And this slide basically enumerates the various causes where you would actually think of doing a diagnostic vitrectomy, where you are lost in making a diagnosis. So you should aim for collecting an undiluted sample where there is either no infusion or it is collected under air infusion to avoid hypotony. A special word of caution in a case where you are suspecting intraocular lymphoma, where you have to stop the oral steroid 2 weeks prior to sampling. The lab is informed of the sample coming to them. The cut rate is kept as low as 600, and all the vitreous sample with the fluid cassette is collected and sent to the lab. Preferably, the plating is done in the operation theatre for any microbiological sample. We must have a list of differential diagnoses in our mind, a plan by the uveitis expert about what tests are to be done after the sample is collected. We should inform the microbiologist and the pathologist regarding the sample being sent for testing for immediate processing, and also to know exactly how they want the sample to be collected, packed and transported to them so that there is no damage to the sample that has been collected. A preoperative preparation, a written informed consent also is required for a diagnostic vitrectomy, and the patient has to be very clearly counseled that you are doing it for a diagnostic purpose and not for a therapeutic purpose. A high likelihood of not having, even after having done a diagnostic vitrectomy, you may still get negative report, and therefore the patient should be mentally made prepared to even face a negative report. And since it's an interventional diagnostic procedure, the risk of complications is always going to be there. So this is a small video where we are going to be detaching the tubing from between, and we are going to attach this to a 2 cc syringe. And then once you activate your cutter, you can collect the sample in this 2 cc syringe. The infusion either can be kept closed or you can attach it to an air infusion pump. And as soon as the hypotony starts happening when you are collecting the sample, you can start the air infusion so that it doesn't dilute your vitreous sample. So after you've collected, please close and rotate the needle so that there is no air going inside the syringe. You cap the needle properly. And if you're doing a microbiological sampling, then it is better to get all the culture plates in the operation theater and do the plating in the operation theater itself. So these are the various culture medias that you see which are being plated in the operation theater. And I'm sure JB sir is an expert in this and he will be helping us understand these procedures better. The test that can be done on a vitreous sample, it can be sent for a microbiological examination, for PCR, for histopathology, cytology, and for immunohistochemistry. And these are going to be all tailor-made depending upon what patient you are dealing with. So these are one of the case examples where we have an 18-year-old boy not vaccinated with BCG, diminution of vision for last 6 months. You see there's a kind of a yellowish lesion in the macular area of the left eye. A hyperemic disc is there, and an extensive subretinal fluid is also present. I did a fundus fluorescein angiography which just showed a stippled hyperfluorescence in the left eye. The provisional diagnosis that I had in my mind was that either it's a tubercular abscess, any chronic infection such as a fungal infection, a lymphoproliferative disorder. On investigations, the other things were all pretty normal except that the Mantux was 0. I really didn't know what I was dealing with, so we subjected this young child to a diagnostic vitrectomy where the sample was collected over this macular lesion and it was sent for examination in the lab. Acid fast staining came out to be negative. The PCR for MTB bacilli was also negative. The culture started having this fluffy white growth on chocolate agar, and it came out to be a gram-positive filamentous bacilli, finally diagnosed to be as nocardia species. And MRI brain was done to rule out intracranial nocardiosis in this patient. The patient was treated and he responded well to the treatment. And you find that the fluid has gone, the lesion has regressed, and the patient has recovered a vision of 6/18 N12. This is another patient of Dr. Vishali. I've taken these slides from her. Who had an atypical presentation of a retinochoroiditis lesion. You see the extensive lesion. And the patient had been treated with intravitreal triamcinolone somewhere else, treated with oral corticosteroids and antitubercular therapy for 8 months and not having any response. And the patient finally was subjected to a diagnostic vitrectomy and came out to be a toxoplasma lesion, treated with antitoxoplasma treatment and with intravitreal clindamycin injections, beautifully showed a regression. And when the patient was again asked that, do you have any snaps where you initially presented? These were the snaps which the patient was carrying, which were very typical of a toxoplasma lesion. And the patient had been misdiagnosed to be having a tubercular choroiditis and treated with intravitreal triamcinolone, which had spread the lesion and led to a very atypical presentation. This is another patient, a 60-year-old male patient who was having a history of COVID. He was admitted in the ICU. And he was diagnosed to have fungal endogenous endophthalmitis secondary to that. And where you see very classical, picture of sub-RPE deposits which were present in both the eyes. And here again, we were a little lost, though it was a very classical presentation. But because he had already undergone a vitrectomy at some other center and being treated for a fungal endoff, this was a repeat subretinal biopsy which was performed by me, where I collected this sample of the subretinal deposit, and this was then subjected to various tests, and this showed that this was in fact a patient of a B-cell lymphoma patient, and the patient was then subsequently evaluated with a PET scan and MRI brain. He was then treated with intravitreal methotrexate injections, and you see this is after 2 injections, after 4, after 13 injections of methotrexate, and this is after 15 injections of methotrexate that the lesion has completely regressed and the patient still continues to maintain a vision of 6/9 and 6 in this eye. So the take-home message is that whenever in doubt and not able to confirm the diagnosis, or there is a poor or no response to treatment, please do a vitreous sampling in uveitis patients. Preoperative ancillary testing to the best of use like FFA, OCT, ultrasound and UBM should be done before planning any interventional diagnostic procedure. A clear plan by the ophthalmologist is essential, with preparation of the microbiologist and pathologist and list of the tests to be done. And there's absolutely no need to control the inflammation prior to diagnostic vitrectomy. Like I mentioned it in a case of lymphoma, actually if you start the patient on steroids, it can actually damage the lymphoma cells, which you will fail to pick up when you've done a diagnostic vitrectomy. So please keep all these in mind, and this is going to grossly help you in managing your patients rightly. Thank you so much. Any questions?